Ladies and gentlemen, dear colleagues, dear friends, welcome to this very first session of the EKS Hot Topics. The first Monday of every month, we'll try to analyze and to visit in depth controversial topics with a speaker and two challenging experts, and we'll try to give answers to all your burning questions. So, welcome to this first session.
So today, the topic is about robotic, and the speaker will be Jan Victor from Belgium, and we're gonna have two challenging experts with Franco Benazzo from Italy and Tilman Kellis from Switzerland. Don't forget to use the chat if you have questions. We're gonna answer and discuss them after the presentation by Jan. And now, Jan, the floor is yours.
Thank you, Sebastian and Michel, for the very kind introduction, and good evening to you all somewhere out there in the cloud. So today is the first session, and we will speak about image-based versus imageless systems. And I'll first perform the share here so that you can see my presentation. There we go. And now you should have an image of the presentation. Does that work, guys?
Yeah, perfect.
Good, thank you. So, for the younger people, I think it's important to rephrase the definition of robotics. And basically, as we are facing robotics today in orthopedics, I believe we'd better call it still computer-assisted surgery, which was back more than 20 years ago defined as a visualization technology that uses computer assistance to track anatomical structures and surgical instruments in real time with the goal of providing increased surgical accuracy. And it works with the principles of trigonometry, so we do owe credit to Euclides, Thales, Fermat, and other mathematicians. CAS works in a rather simple way. It has an input, which is the camera, with at least two sensors. And then we use either active or passive reference frames. The active ones send infrared and the passive ones reflect infrared light. The computer is putting everything together, and then the out screen is either a screen or a robot. And in my view, that's not so much of a difference. Here you see a graphical illustration. The light is being emitted, reflected by the spheres. The software calculates the third dimension based on the different reflective angles, and that allows you to track either instruments or the bones. But before you can start tracking, you do need a so-called Cartesian coordinate system. And important to understand, that system is independent on the femur and on the tibia. So both bones have their own reference system. A reference system that, as we call it, is based on relevant landmarks. And here it's very important to understand that some of these landmarks are inaccessible. They can't be seen or they can even be touched, as for instance the center of the hip. We don't really know where it is. And the center of the ankle also has a relative definition based on the intermalleolar distance. Important to realize, and we'll come back to that. And then other relevant landmarks, they can be found, but it's very hard to pinpoint them precisely during surgery, such as the epicondyles on the femur or the definition of the sagittal plane on the tibia. So it's very important to keep this in mind. Now, why is a correct definition of that Cartesian coordinate system so important? And the first reason is geometric. This nice drawing was made by Hannes Vermeulen. He wrote a paper very recently on the subject, which will be published in the near future. And what you see is, as you turn your reference system by 10 degrees, the blue versus the red, a cut in the coronal plane, which has some slope in it, will all of a sudden become either a varus or a valgus cut. So when you're off with your coordinate system, your complete geometry is off, and you do not know which type of alignment you are using anymore. The second reason why this coordinate system is so important is kinematic. As you do make mistakes at the level of the distal femur, for instance, your implant will not follow the so-called optimal flexion axis anymore. This axis does exist, and we did several cadaveric experiments in order to find out what the exact location of that axis was. Anatomically, it's basically the line that connects the centers of the best fit spheres in the condyles of the distal femur. And we know that in the horizontal plane, the surgical transepicondylar axis is parallel to that line. At the level of the tibia, Justin Kopp published a very interesting definition as where to put that transverse axis of the tibia. As we used our experiments with the optimal flexion axis and the parallel transepicondylar axis, surgical one, we found out that the projection of that surgical transepicondylar axis on the tibia is almost collinear with the tibial axis, and in flexion, the mechanical axis of the tibia is perpendicular to it. So, easier said than done, you need to find this axis, the femoral transverse axis, and you want your coronal plane to be perfectly parallel with it. Obviously, there are tricks, and we know them from ancient literature, how to reference of the postecondral line, the surgical transepicondylar, or the trochlear, or so-called white side line. But remember, all of these values are average values, and there's a rather big standard deviation. So in order to find the optimal flexion axis for an individual patient, we'll need something else, or you will be off in quite a significant number of patients. Robert Sisson showed a long time ago, more than 15 years ago, that it is very difficult to find the correct rotational axis in the distal femur with traditional means. And you see here the graph from his original paper. At the same level on the tibia, we face a similar problem. This is work by Hans Vermeulen, and he looked at a systematic review of the literature and reviewed all papers that have been written on the anatomy of the proximal tibia and the position of the sagittal plane of the tibia. The most reliable ones, and I mean with reliable, those axes or definitions that can be found repetitively, consistently by different surgeons, and also that have a small standard deviation. The most reliable ones are the anatomical tibial axis, the anterocondylar axis, and the line connecting the PCL to the tibial tuberosity. But remember that all of these definitions were found with image-based systems. So it's very important as you go through the literature and these nice definitions, everything was found with image-based conditions. So let's take the next step now and look at what we can use in image-less conditions. At the level of the femur, the center of the head, femoral head is found kinematically. So that's an indirectly derived reference point. For the tibia, the center of the tibial plafond is found as it is relative to the malleolar intersection line. Again, an indirect derived axis or point. Direct points that you can pinpoint precisely are the center of the distal femur, just above the notch, and the center of the proximal tibia, which is usually defined as the center of the insertion of the ACL. These are reliable landmarks. But then, and that's a problem, in imageless conditions, the rotational landmarks for both femur and tibia are not to be found with great precision. And that is a potential problem that could lead to a malrotation of the femoral and the tibial component at the end of your operation. So what about image-based CAS? And the first, or robotics as you wish, but the first thing I'd like to say, this is not new technology. We used that starting in 2002, and you see here an old fluoroscopy machine where we took biplanar X-rays during the operation, allowing us for the first time to use computer-assisted surgery, which was based on an image that was taken intraoperatively. Obviously, this is old technology, and today we have newer systems that can merge CT or MRI STL files with the geometry of the patient. We have also shown in the past that it is possible to retrieve these important landmarks on a CT scan in a highly relevant and reproducible way. So the precision of marking the points on the CT scan is quite good. Let's now make the move towards the robotic systems. And this might seem as a busy slide. It is also a busy slide. And it shows us the commercial systems on the market in green, the Mako, the Navio Cori, the Omnibot, the Rosa, the Willis, and the Think Surgical robots, and relates them to certain features like imageless or image-based, which kind of control, is there a boundary control, a dependent gap analysis, what's the footprint, what sort of implant can you use with it, and what are the published outcomes. As you can see, immediately published outcomes rather limited for most of these systems, which is normal because they are new. Looking at image-based systems, we only find Mako and Think Surgical. Interesting, both of these have a so-called boundary control. That means that you know how far your saw blade will actually penetrate the limits of the bone and might damage the soft tissues. Now, you might think that in your hands this doesn't happen, but we did a small study with some experienced staff and some residents, and then last year trainees, and we found that the excursion of the saw blade is actually far greater than you would expect at first sight. So this might be more of a problem than we all assume, and it also might be a reason to actually move to boundary control as we perform the operation. The other four systems mostly work in an image-less condition, and they have different features. It is not in the scope today to discuss all that, but I'd just like to show you which systems are mostly imageless and which systems are more image-based. The downside of imageless is that you need to point the surface of the bone on the distal femur and also on the proximal tibia. And again, as you see, this is not that difficult as you stay relatively anterior. One of the problems is that as you want to move posterior with your instrument, it's very difficult to access before you have made the femoral cuts. So the backside of the tibia cannot be accessed easily with this technique. Also, the image that is created by the computer is not reality, but is taken from a statistical database that comes as close as possible to the points that you have shown to the computer. As we come to the definition of the sagittal plane, and so the rotation of the tibia, you have to be aware that this step pointing the medial 1/3 of the tibia, again, can be prone to rotational error. It is not that easy to do, and we are currently performing experiments to see how accurate we are in defining that point, and with that point, defining the sagittal plane, the coronal plane, and the whole rotational issue of that operation. So a very important step not to be forgotten. One specific system is using a different solution. They transfer the optimal flexion axis, the surgical transepicondylar axis of the femur onto the tibia with a knee in full extension. And that will work well as long as the knee can achieve full extension. But as soon as there is a fixed flexion contracture, that might actually again be a cause of rotational errors with that technology and algorithm. So, in conclusion, the image-based robotics in Pro have a very accurate definition of the geometric axes and planes, and I think that is really crucial to have an accurate outcome of your operation. They allow for a good pre-op planning, which can be interesting, so you don't have to do it during the operation, and as I have shown you, there is boundary control. Arguments against are the cost of the CT or the MRI, and not to be forgotten, the time we spend at pre-op for the planning of the operation. As we go through the imageless robotics, in favor, there is no need of imaging pre-op, so there's no hassle, no organization, no cost. It is logistically easier. But the arguments against is that you don't have the real geometry of your distal femur and proximal tibia. It's a statistical shape library. There's an increased acquisition time, and personally for me, I don't like that. I don't like the painting of the surface, and that is something that can be the time gain if you use image-based systems. Intra-op planning can be cumbersome. You have seen the reflections on the screen, which might pose a problem. And in my view, we have more issues with rotational alignment than we are ready to admit. Now, a next step could be the acquisition of a rich 2D, 3D intra-op dataset with a three-dimensional visual camera that is capable of making a good image of the distal femur and proximal tibia and merge that with a pre-op STL file taken from a CT or an MRI. That would allow trackerless navigation. It is very fast in registration, and it could provide an important step forward, as you don't need to put the pins in the femur and the tibia anymore. And here's my final slide to finish off in 15 minutes. My ideal computer-assisted system would be image-based. It has to be versatile, lean and swift, not like this big thing. It should be intelligent and have a clear interface. It doesn't look very intelligent near clear. It should have an integrated gap balancing. I would prefer not to have trackers and pins. I would prefer to have a boundary control. And finally, it should be affordable. With this, I would like to conclude. Thank you for your attention, and I'm ready to take on some questions. Thank you very much.
Thank you, Jan, for this excellent presentation with a good overview of all the existing system. So, Franco and Tillman, that's up to you now.
Yes, Michel, I am reading. We got a question from one of the attendees to this webinar, and this is a question that Jan should answer directly. What is the mean standard deviation of the image basis robotics?
Yeah, it's a rather general question, because if you talk about the standard deviation, you need to talk about the angular deviation for the axis and the millimeter deviation for the points. It is within 1 millimeter and 1 degree. So it is very, very accurate. There's much more standard deviation in the image-less techniques, which is easy to understand.
Jan, I have a question. So you pretty well pointed out the potential problem of getting the tibia rotation correctly, and even to get the axial plane, like the slope correctly of the tibia. First question is, in your hands, how important are those two parameters, like tibia slope and tibia rotation, in the clinical field? And the second question now is about the femur. Whenever we work with standard models, we have like a generic trochlea that is more or less parallel to the posterior condyles, not necessarily representing the individual anatomy of the patient. Can you also make a comment on this image-less versus image-based? Please, these two parts.
Yeah, okay, Tim. I'll first tackle your question on the slope and the rotation. It is obvious that when you aim at 0 degrees slope, then the initial rotation of that tibial reference frame is not important anymore, because you can come from every angle. But as soon as you add slope, the rotation becomes important. And there's a paradox here, because at the end of an operation, you align your tibial component with the femoral component, because you want them to be well aligned in rotational position near to full extension where the heel strike happens. So it is important to have it right in the beginning, because then your chance of having a slope as you intended it to be is greater. My personal technique is including very little slope for the PS knees. I try to put them almost neutral because of the fact that in a PS knee, you close up a little bit your flexion gap, which adds to the stability, and you don't need as much ACL function as you cut out ACL by reducing the slope. But that's a technical issue relating to stability. Now, your second question was in relation to the rotation of the distal femur and the femoral component. I think there the utmost importance is not so much a trochlea, but is the relation of the two condyles towards that optimal flexion axis. And as you are off in rotation, you will have a position of slackening and tightening the collateral ligaments, which might be a cause of instability and pain in the patient. So that is for me the main reason. I don't see so many problems with the patellofemoral tracking in the modern prosthesis because the trochlear groove has a nicer curve and the patella is better designed. But the collateral ligaments do suffer a lot as you have your femoral rotation wrong. Did I answer your question?
Yeah. So I'm a little bit controversy on your last point that the trochlea is of lesser problem. So my personal experience is that it's very valuable on the image-based robotics that we also have a visualization between the dependency of the posterior condyles to the trochlea orientation, so that we can do some compromises, especially in kinematic alignment, where we would alter the native trochlea when just reconstructing the posterior aspect of the knee. And to me, this is a great benefit for the image-based systems that you really have a visualization of the individual trochlea.
Sure. And as you take that point, Tilman, you're actually going into next week, because talking about kinematic alignment and alternative alignments, you need to adapt your implants as well, because there it's in a different position. The valgus position of that femoral component will change as well. It's not just the rotational position, but also in the coronal plane, the valgus position is different because of the kinematic alignment.
Yeah, I would like to make one point that all the discussion between imageless and image-based could be biased a little bit by the fact that the system that we are using, each one of us, are strictly bound to one specific design of prosthetic replacement, and this also drive our final decision. So please, just a comment that, because a warning for the attendees. One point are the main principle of the knee surgery with robotic system. Others are the points of the specific decision making during surgery because of the design we are using, concerning the J curve, the thickness of the posterior condyle, the design of the liner. So we should be able to specify a little bit what we are telling, considering the system we are using. Do you agree, Tilman? Do you agree, Jan, Michelle, you and Sebastian as well? Because this is absolutely important. In the moment we will have open systems for all prosthetic design, probably we will have a common basis of discussion, more understandable by everyone.
But when you choose between image-based or imageless system, is the philosophy of alignment in the balance? Does it influence your choice? Or what do you think?
Personally, it doesn't influence my choice. I'm sorry that I'm taking the word instead of Jan. Personally, it doesn't change my choice, because the system I use, it could be imageless, it could be image-based. And I just published a paper with 75 patients demonstrating the accuracy of the bone cuts according to the image-less acquisition of the landmarks and all the points described by Jan. This does not mean that automatically I will have immediately or later on good clinical results, but accuracy could be as good as in the image-based procedure. There are other advantages for image-based system I use, because we have the possibility of removing the metal of the implant and seeing where the bone cuts can go and so on. But this is common to all the system. This is also for macro and analysis.
I'd like to come back to your first point, Franco. I think you made a very important point, and it was in the slide fact that all these systems, except for things surgical, are brand restricted. So we are actually tied into an implant as we use a certain system, which makes it very difficult to compare one system to another. And it does deserve a big discussion, I think, in the near future on how we should proceed with these systems. Cecile, there's a lot of echo in the system here.
Yes. Yes.
So,
Jan, we have a question regarding you made a very good point for image-based system, but some of the surgeons attending is asking if there are any evidence actually that it does improve the accuracy or the outcomes compared to imageless.
Yeah, that's a very good point, and we are currently performing experiments to see whether the claim is true. You have to realize that the accuracy values we get today are published by the company, so there's no objective or independent person or group that has looked at that in great detail. There are a few studies out there, but to really compare image-based versus imageless, you need to set up a very strict protocol, and we are currently doing it. And I'm aware of a publication that was sent in, and I reviewed it last week, so it's coming. And I'm very sure that in the near future we see some experiments that compare these two technologies. And I've always been a little how would I say, not at ease when I was using these image-free systems, because you assume the algorithm and you think, okay, there's an algorithm and it will be correct. But think about the way we point to the malleoli. Where do you point to the malleoli? Is the tip of the malleoli or the most prominent point? And it's easy to understand that your pointer might be 5 millimeters more anterior or posterior, or a little more medial or lateral as you point to the medial lateral malleolus. And then you have an algorithm saying, okay, we assume the center will be 40-60, that distribution. But I think that's already off by 3 or 4 millimeters in many patients. But we assume it because it's in the system and the algorithm is there. But we need to be much more critical in looking at these systems, I think.
I fully agree with you, Jan, because it's a matter of mutual understanding. So the surgeon should understand how the software or the device is using works, and the bugs and the downsides that the program, the specific program or the software can have. And so the acquisition of the points can become more and more precise as long as you are used to know how the software works. The other point, and I would like to know also the opinion of Tilman in this point, that at least in my system, if you use an image-based procedure, you should be able to take exactly the same point chosen by an unknown engineer on the other side of the world, providing you the planning during 5 working days after the acquisition of the CT scan or the X-rays. We don't need the CT scan on the X-rays. And if the acquisition of the points you have done intraoperative does not match with the points chosen by the engineer, you cannot proceed. So you must rely, as with PSI, as it was in PSI, with a decision taken by someone else, including the size and of the tibial and femoral component, which is not the most important part of the surgery, because as you very well pointed out, the most important part of the surgery is to define the gap assessment. And most of the system are still manual, only one is not manual, and the rotation both of the femur and the tibia. So despite we can have the image-based procedure, we are not improving very much in the precision and in the decision-making of the planning. So still we have a big holes to be filled with the software, hardware, and the manual skills of every single surgeon.
I would like to first comment on this point. I'm perfectly with you that it is critical just to rely on some structures that is defined by an engineer who has never seen a surgical theater from the inside. However, with the system I daily use, it's an image-based system. I have the opportunity to really go through the whole planning process. So that is not a black box like we have seen it in many PSIs, but it's a whole, a very transparent system where you can go through all the landmarks that were set. We can validate the landmarks, and we can even change the landmarks. And that is really interesting because just what Jan Victor said about the tibia rotation, we routinely go in the CT scan on the femur and set the tibia rotation landmark based on the femoral landmarks, right? Based on the posterior condyles, based on the trochlea, and then copy that to the tibia, and even are able to check that with the ankle joint orientation, right? And those really, to me, are the very interesting features that we are using, not only to get a plan, but really to validate the plan and have a good idea. And I would like to go on with the question concerning the outcome, and is there any evidence that the outcome has improved? So I just finished a review on what is the current evidence base for outcome in robotics, and I was surprised that it's pretty positive. Like there's a new meta-analysis published this year saying that the outcome in total knee arthroplasty is improved by the use of robotics. And the interesting thing here was that especially the publications aiming for an individualized alignment, like inverse kinematic, whatsoever, they were really able to show a benefit with robotic surgery. So I would like to give this question back to Jan Victor. Where do you see the greater benefits, image-based versus image-less robotics in terms of individualization of the treatment, or is there no difference from our current knowledge?
Let me maybe first comment, Tilman. You made some very interesting comments on the point that the literature is showing better outcomes for robotic surgery. I truly believe we have to acknowledge a big bias here, because these studies were made by people who obtained a robot like 3 years ago, before we get all the study data, and then the publication is 3 to 4 years. So that's the early days. And then imagine you convinced your board of directors in the hospital to buy a robot for you, or you invested $500,000 or $1 million or euros in a robot. And then you install the robot, you convince your patients, you make big publicity on the internet, and then you perform the study. There's a big bias here. And it's very difficult after you have done all these efforts to say, well, it's just as good. And I read a paper just 2 days ago showing that there was no difference between robots versus manual techniques. So we'll need to take an honest look at that, and it'll take time. And I'm convinced one day the outcome will be better. But if you think about what navigation can do exactly the same as robotics. Navigation was introduced more than 20 years ago. It was a big hype, and it went away almost completely, except for Australia, that has a penetration now of about 20%. So if all that is so superior, why didn't we continue with navigation? There's nothing that a robot does today that we couldn't do in navigation. Even the gap-dependent technique was developed by BrainLab with the Pew, with nice curves showing you the gaps, not just at 90 degrees and in full extension, but the full range of motion. So the whole technology was available, but it wasn't called the robot. Today it's called the robot. There's a big fuss about it, and I truly hope it will be better. I think one of the major advantages might be the penetration of the saw blade. So the boundary control, in my view, could be a big difference, as you don't have these small damages or bigger damages to the capsule, to the ALL ligaments, to the popliteal tendon. All these things happen, and if you can control the saw blade in a better way, that might be, as of today, a big advantage, so soft tissue damage. The other thing, what about individualized alignment? And again, I'll be the devil's advocate. I think alignment is overrated. Big thing in these is stability. If the patient is stable, he's usually a happy patient. So I'm not so sure the individualized alignment is perceived better because of the individualization of the alignment, but maybe because of the better stability. And again, that is only an assumption, and we'll need to be able to prove that with very, very good systems that can measure outcomes in patients. I'm sorry for the complicated answer.
No, no, and Jan, I have a question. You speak a lot about the weakness of the statistical shape library, and you prefer a real image based. But there is a question in the audience. Something say that, but the statistical model is not used for calculation of positioning, but rather for usability and for visualization. So, what do you answer to that? Do you think for you it's interesting to have real image mostly for to check that you don't damage the soft tissue, or
Yeah, I'm thinking a step further. If you want to evolve towards a technique where you replace the amount of bone that you take out with your operation with exactly the same volume of metal or plastic comparing to the original shape of the cartilage before it was damaged, then it is very important. With the imageless techniques, you make sort of statistical measurement and you don't have the reality. So if you want to talk about millimeters, and people who are favoring a single radius versus a J curve or vice versa, they talk about millimeters. The difference between a J curve and a single radius in the sagittal plane is 1.5 millimeter. So these are small differences. Maybe they are too small to be important, but in the end, if you want to get to a higher level, we'll need to be talking about details.
okay. If you want to be accurate, you need to be accurate everywhere.
I think so.
And guys,
yeah.
may I ask a question also? Because we speak a lot about the improvement of the patient's outcomes in the accuracy, etc. But do you think that we could also appreciate the interest of robotics with other metrics? For example, the simplification of the workflow in the operating room, less sterilization, less box, less instrument, decrease the cost, modifies the risk of infection, decrease the time of surgery. What do you think about all these points?
Decreasing the risk of infection, have to see it. It's a big machine that you bring in, something that was not there before we started with robotics. Reduction in cost, so far, I think it's difficult to say. We published a paper on cost and value in robotics, so that's also something that's worth the discussion. To get rid of the trace, yes, if you can 100% rely on the robot. And for the moment, I'm not sure. I didn't work with all the systems, but the systems I have used, I've had to switch to an instrument set from time to time. So you still need them in the OR. I truly believe, Michel, we are at the beginning of all this. This is fantastic. It's a first step. And as you know, many innovations are overestimated on the short term, but they're underestimated on the long term. That's exactly what happened in navigation. In the beginning, it would change the world. Then it showed not to change the world, but now it's gradually coming back with the robotics. And then the robotics system will again evolve. We are at 1.0 in the robotic systems. It's very crude, it's very rudimentary, and we will need to evolve. And one day it will become something of true value. But as of today, hard to prove, I guess.
Jan, do you think that, don't you think that the robot and the accuracy of the robot would be the only way to go to reach the the customized and the real individualized, not only alignment but implants?
Do we need a robot to use customized implants? Is that what you said?
Yeah. I mean, because when we talk about customized implant and then we use custom cutting jigs, patient-specific instrument, the accuracy I don't think is there. Don't you think that the robot is going to allow us to do a better job?
Very, very true, Sebastian. And I think it's an and story. So it's quite clear that you cannot talk about differences in 1 millimeter in your geometry of your implant if your cuts have a precision of less than 5 millimeters. Then you're way off. So in order to obtain that alleged advantage of your customized implant, you'll need to be able to perform very precise cuts that are repetitive and exact to the point every single time. Yeah.
there are two facets of the quest for restoring anatomy, and customization of implants and robotic are complementary, in fact.
You are biased, Michel. We will give a talk on the customized implants. So you are very much
Yeah,
biased.
so it's an introduction for next time. Eh?
Yeah.
Yeah, but listen, I got the same observation done by Jan that robotics is, well, we say 80% navigation and everything was still there 20 years ago. And we need boundary control to avoid the damage of the possible small or big damages to the soft tissues. But I do think, at least in the two systems I've used, that the precision of the bone cuts and the aid given by the robotic arm is very important. It's an addition to the fancy sometimes placement of the cutting slots with the navigation when I started with the navigation many years ago. So I am more precise with the bone preparation. Another very important point is that we should have imageless or image-based wise, whatever, a better way for assessment of the gap. The gap analysis is still too much rudimental. And therefore, I jump in the final comment of Jan. It's true, we are in the prehistoric era of robots. And but I think it's important we should stay there, because it's with discussion we have right now this evening, then we can improve ourselves, we can improve our knowledge, and probably we can influence the decision of the companies in adding technology, software, and implementing everything in the robotic surgery.
It's a good point, Franco. And matter of fact, if you think about it, we have a very sophisticated machine, at least we think it's sophisticated. And then we measure the gaps with manual force, as you
Correct.
said, systems, except for the omnibots, do that. So that's very counterintuitive. And I'd like to go back to that comment that's here. Is not one of the big differences compared to the earlier cast, that robotics allows anticipation of the gaps. And if you allow me, I'll show you a very short video of an old cast system, and take a look at it. It's quite funny to see. Share screen, and then just a second. Window, there we go. Okay, now you should see it. Forget about the text that is on the slide, but please take a look at the video. It's the old BrainLab system that was using the ligament tension and the gaps that were available, and shows how the expected gaps, medial and lateral on each side.
Jan, we don't see your screen. You should
You
share.
don't see it?
Yep.
Oh, sorry. That's a shame. Why is that? Image-based versus image. I will try again. Do you see it now?
Yeah.
Okay, so
Excellent.
forget about the text. Do you see the video play?
Yeah.
Okay.
Yes.
So you see, as the femoral component is changed in position, you can see the immediate effect on the gaps and on the alleged tension on the medial and lateral collateral ligaments and capsule. So that system was pure navigation, nothing to do with robotics, but it already integrated the gap balancing. So nil novo sub sole. This is old stuff, guys, and it's nice, because if you understand where the things come from, then it's better to understand how the industry works and why certain things get into an evolution. But it's a good remark. Thank you.
I'm perfectly with you that most of the technology have already been there. Even the navigation systems in the very beginning started with image-based navigation, and they were too complex, too complicated. And a CT scan at that time was too complex to get segmented and all those things, so that they were made easier with the image-less technology, right?
Mhm.
But now with new knowledge and new computers, we have the possibility to even go back to more complex technologies in my hand. And one of the biggest difference in my hands is that we also were changing our workflows, right? Because with the navigation, we already had those tools for predicting the soft tissues. But today, at least in my hands, we are doing some pre-cuts so that we can access the ossifieds. We perfectly know where the ossifieds are based on our image-based technologies. And then we are analyzing the gaps, and then we are doing our final alignment and doing our definite cuts, because this is super precise and super accurate with the help of the robot. Doing a 1 millimeter and 1 degree recut is a different story in my hands with the use of robotics compared to CAS. I'm perfectly with you that the most important technology is those navigation and those virtual planning, and the less interesting technology is the robot itself. But in the very end, it enables us to do those recuts and those new workflows and those new ideas to align a knee joint.
Jan, we have a question from the attendees, a few questions. So one is, robotics generate a wealth of data. How could we, or what are the important steps required to facilitate data mining and analysis in future studies? Tough question.
It's a good one. And since the beginning, everybody was talking about closing the gap. So we would play with the position of the implant. We would then measure the patient's function and have all sort of wearables, and then integrate this into artificial intelligence, and that would then feed back into the ideal position of an implant for an individual patient. It's a nice thought, it's a nice slide when you present it, and it's fantastic as an idea, but as of today, the gathering of data is extremely complicated. To give you an idea, in our country, the legislation on which data can be stored is very complex. Same in all of Europe with the GDPR legislation. Then again, even if you solve that, who is the owner of the data? Is it surgeon? Is it the patient? Is it the company that built the robot? Or is it the hospital? And that question needs to be answered, because if it's not the company that built the robot, then the hospital could sell the data to the company, or the surgeon could sell the data to the company, or the patient could sell the data. So it is very, very complicated. And again, one day we'll be through and we'll find a solution for all that. But so far, I've seen a lot of talk about gathering data, but I have seen very little practical value of it as of today. And again, this is a moving target. My presentation was made on the moving target. The thing is evolving very rapidly. But I'm very anxious to hear what the other faculty members think about data gathering. Have you been gathering data, guys, with the robot?
Franco, Timon?
Yeah. Well, again, I agree fully with you. It's like the discussion some years ago with electric cars. Who is responsible for an accident during automatic driving and so on and so on. It's exactly the same thing. I think that we go through these issues. As a matter of fact, the system I use, and again, we are too much bound to the specific system used, but I'm able to reconnect the prompts of the patient with the intraoperative data. And I don't know if I am the owner of the data, the machine is the owner of the company or the hospital, but it's an important step forward in understanding what we have done during surgery can be a good thing for the patient or not. And I am matching all this data with gait analysis of the patient. So again, we are stepping over in progressing in knowing what we do during surgery, what will be the behavior of the knee, and the satisfaction of the patient later on. As a matter of fact, there is another question, Jan, that you should answer, just to allow space for the attendees. the observation of this colleague is that robotics should allow anticipation of gaps, and CAS didn't do that, didn't allow that. Is it correct or not?
No, because the video I just showed was actually an anticipation of the gaps. But again, this can be improved very much. There's one system now, it's definitely not perfect, but it's a first step in standardization of the force that you actually use to open up the space between femur and tibia, and then do that throughout the full range of motion. It would allow you theoretically to have a good prediction on what gaps you need and what position of the femoral component you need in order to have a knee that is as stable as possible. Because quite frankly, it will always be a compromise. You either stick completely to the geometry and to the alignment, and then you adapt ligaments to that, assuming you can adapt ligaments, because that's very complicated. Or you say, I fully follow the ligaments, but that means that you will have some outliers in your alignment. So if we are honest, we need to admit that our surgery is far from perfect. It's a compromise between geometry alignment on one hand, and then ligament stability or ligament tension and stability on the other hand. And it's our task to make the best compromise. Can the robot help in doing that? Yes, I certainly believe the robot can help in finding the optimal position of that femoral component relative to the already defined tibial position, and then have a solution that is maybe not perfect, but as good as it gets.
So on one end, we are going back to the mesoresection gap balancing battle. And we all know that with robotic surgery, we can be precise and merge the two techniques according to the steps of the surgery.
Yes.
And I fully agree with Tillman that the precision allowed by our robotic arms is far superior to our manual precision that we can have sticking in with the 2 pins a cutting slot to the bone. And this is very imprecise. So that's the big advantages of the robotic surgery. Tillman, I think that you agree because you just mentioned that. And going further in this discussion, there is another question. Do you think robotics has a role in mechanical alignment technique? Or if you begin with robotics, you should explore new kinematic or personalized technique? I have an answer also for this, but Jan, please, Tillman, Michel, Seb.
Yeah. I think it definitely can have a value regardless of which alignment technique you use, because it adds to the precision and the reproducibility. But the most important thing as you start, I think, is you need to learn how to work with it. It changes your surgical technique. It is a big machine that can be in the way. So I think the learning curve is very important. I think you need to understand the algorithm that you're using. It's crucial in my view. And then once you master all that, you can start with maybe adding in some of the variations you didn't dare to do when you were using manual instruments. But I think the order of the steps is very important, and the learning curve is realistic. There is a learning curve to it, no doubt about
it. If I can add a comment, I have just compared 50 patients done with the navigation system with accelerometer, and the 50 patients done with my robotic system. And very interestingly, the alignment obtained with the navigation system was within a very narrow Gaussian curve, while the alignment obtained according to all the data, all the different parameters we've been talking about, gap balancing, gap analysis, and image, the landmarks acquisition, and so on. The final alignment in the 50 patients done with the robotic surgery was on a much broader Gaussian curve. That means that at least in my hands, I have evolved in choosing the alignment which can give the best stability on the knee, and which is not forcefully a mechanical alignment or a constitutional alignment or whatever. And I think this is very interesting because that's what the papers we read many years ago on the navigation we are showing that all the cases got the same perfect mechanical alignment many years ago. But this does not mean automatically that this could give the best clinical results of the patient. And so I think that if we apply in the proper way all the possibility given by the robotic surgery, software, gap balancing, gap analysis, and so on, and precision and accuracy in the bone cuts, we can personalize the alignment for the patient. Sorry for the long remark.
Yeah, Jan,
but Franco, there is a question for you.
Yeah. Exactly, there is a question.
Yeah, I will try to be very...
Which final gap are you aiming at? Symmetrical gaps medially and laterally? In extension and flexion, you stick to the kinematic plan. Does the robot affect your gap targets? First of all, the only system that is capable of measuring the gaps in a reliable and standardized way is the Omnibot. Hannes Vermu is currently working on all the data. I don't think, to answer your first part of the question, you necessarily need to be equal medial and laterally. The anatomy and the function of the medial and lateral compartment of the knee are fundamentally different. The lateral side of the knee is dynamically stabilized by muscles. The medial side of the knee is very passively stabilized by a strong and stiff medial collateral ligament. So there is an anatomic and functional difference medial to lateral in the normal knee. If you think about a varus knee, patients who walk with 10 degrees varus for a long time, they all have stretched their lateral capsule, they have stretched the lateral collateral ligament, and you cannot actually put them back in a perfectly stable situation on the lateral side. So my surgical technique is based on the medial side of the knee. I want the medial side of the knee to be isometric, to be stable, and to have an as equal flexion and extension gap and mid-flexion gap as possible. So I try to reproduce that perfect curve on the medial side and adapt to the lateral side, allowing for much more laxity and even different gap measurements on the lateral side. So I think in a concept for me, that's the important part of the operation.
I fully agree with you. These are my targets, precisely. I don't agree with you when you say that only Omnibotics can allow this precision in the gap balancing, because Tilman, please make your comments on your sensor that you can use after the bone cuts, and you can go back and make some correction, because in your system, these sensors are available.
Yeah, well, I wouldn't say that the Omnibot is the only system to do it reproducible or reliable. But yes, I'm with you. It's the only objective measurement that is guided by pressure sensors, right? And we know that even with a pressure sensor inlay, you can cheat and get the numbers you want to have, right? That's obvious, and that was pointed out before. That still the measurement of the ligaments and the gaps is one of our most critical parts. And even when we completely rely on those measurements in terms of position of the implants in a virtual environment, then we are very, very depending on a very strict and reproducible measurement. But I'm completely with your targets that the medial compartment has to be stable and isometric throughout the range of motion, and the lateral laxity is less a problem, especially in flexion. But also this depends on the overall limb alignment. So if you leave the knee in a severe varus, then a lateral laxity and extension, like a varus thrust phenomena, might be a problem. So, but in principle, that is the target.
Jan, we have 1 minute left. Do you want to give us your final words on this topic before I introduce the next one next month?
Yes, thank you, Silas. That's too much other. But thank you all for listening. And I believe we are at the step, at the verge of something greater to happen. And I'm truly intrigued by all the efforts in the industry. The task of industry is to innovate and to provide marketing around innovation. So that's very important. And I think we need to collaborate with all of the companies, not just with one company, but all of the companies in order to achieve a higher standard in the arthroplasty. That's my final word. Thank you very much.
So thanks a lot, Jan. Thanks a lot, Franco and Tilman, for being the challengers. And I think you really challenged Jan on a lot of the topics, and we had a very nice discussion during this 1 hour, and Michel as well. Next month, it's going to be another hot topic. It's about custom only, and it's going to be Manu Tiampon, who's going to be the speaker with Michel and Carsten Tibescu as challengers. So this being said, I would like to thank again the European Knee Society for getting these hot topics, started with this topic on robotic, and thanking BMED for also organizing the practical aspects. And wishing you a nice evening, and seeing all of you next month for the next hot topic.
May the 2nd.
Yeah, May the 2nd. Bye-bye.
Thank you. Bye.
Bye-bye, everybody. Bye.
Bye.
Thank you.